Hello, this is Author Spotlight for the month of May. I'm Patty Pellikka, Editor-in-Chief of Journal of the American Society of Echocardiography. The May issue of JASE is entirely devoted to the topic of echocardiographic assessment of diastolic function and heart failure. Visiting with me today is Dr. Katie Young, Senior Associate Consultant in the Department of Cardiovascular Medicine at Mayo Clinic in Rochester. Dr. Young is an expert in echocardiography and cardioobstetrics. Welcome, Dr. Young.
Thank you so much. It's great to be here today.
Dr. Young is lead author of the paper, Association of Impaired Relaxation Mitral Inflow Pattern, Grade 1 Diastolic Function with long-term non-cardiovascular and cardiovascular mortality. Katie, what prompted you to do this study?
Well, that's a great question. And we've known that diastolic function or abnormal diastolic function has been associated with cardiac outcomes and mortality and heart failure. But we really wanted to address two main issues. One being, what is the specific cardiovascular versus non-cardiovascular mortality outcomes related to diastolic function, and really wanted to focus on the impaired relaxation mitral inflow pattern or grade 1 diastolic dysfunction. And really evaluate that in more detail to better determine, is this really something associated just normal with age, or does it carry implications in terms of outcomes for the patient?
Great idea. We do see that all the time as patients get older and have been wondering about the significance of it. Tell us about how you conducted the study.
So for this study, it was retrospective, and we utilized the Olmsted County Heart Function Study. So this was a database which was created from a random sample of population patients within Olmsted County. And they had serial echocardiographic data, but we used their last echo in their series of assessments through this study. And we then used the echo data and graded diastolic function based on our Mayo Clinic criteria. And the main exclusions here is that we excluded those with a diagnosis of clinical heart failure. We excluded those with reduced ejection fraction. And then we excluded anyone whose diastolic function was indeterminate. So that may have been because they had significant valve disease or conduction abnormalities, etc. But those individuals were excluded.
So what did you find?
So with this study, we found there was actually multiple components to this. So first, looking at all-cause mortality, we did find that across the board, diastolic dysfunction, so grade 1 or grades 2 and 3, were associated with worse all-cause mortality outcomes. And this wasn't per se new. This has been shown in prior studies. But what we did with that grade 1, so those with impaired relaxation pattern, so that is those that on the mitral inflow have that E less than A, so that E to A ratio is less than 0.8. We maintain that distinction of grade 1. And in those individuals, we then separated that grade 1 group and removed those with any kind of clinical diagnosis of diabetes, hypertension, coronary disease. We excluded anyone with dilated left atrium, wall motion abnormalities, and we were left with purely a group of patients with what we called isolated grade 1 diastolic function. And what was novel in this study is that even those individuals, removing all those with other clinical or echocardiographic abnormalities, they still showed an association of worse all-cause mortality outcomes. So that was really significant in that, this is not maybe something that's just normal for age, but really is a biomarker for our patients.
Oh, interesting.
Yes. So that's a main thing. We also then looked at non-cardiovascular outcome and cardiovascular mortality outcomes. Not surprisingly, in non-cardiovascular mortality, after adjustment for comorbidities, the diastolic function did not remain associated with non-cardiovascular mortality outcomes. In comparison, for cardiovascular mortality, again, across the board, abnormal diastolic function was associated with worse cardiovascular mortality outcomes, even after adjustment through a multivariate model.
Did you find any surprises?
Yeah, I would say the biggest surprise I think that we found during our evaluation and during this study is in the non-cardiovascular mortality outcome data. So while we found that association with diastolic function did not remain significant after adjustment for of many things in our multivariate models, we did find that the biggest causes of death were cancer and dementia. And then when we looked at those causes of death in relation to their grading of diastolic function, we actually found that individuals with grade 1 diastolic function had increased risk of death from dementia, which was surprising. But there have been other studies that have shown some markers related to cerebrovascular health and abnormal left atrial strain and such. So we thought that this was an interesting and surprising finding that we identified during the study.
So how should this information be used in clinical practice?
So I think the big take home here is that I think it's important that we identify that impaired relaxation pattern when it's present and identify it as grade 1 diastolic function or dysfunction, rather than calling it normal, because it does carry implications for outcomes for these patients in our study. And so I think then putting that into the significance for your day-to-day practice and when you're seeing these patients, I think of it as placing them on that spectrum of preclinical diastolic dysfunction or preclinical heart failure. And really, I think is an opportunity that when we see this as cardiologists and clinicians, that these are patients we do really want to be aggressive about risk factor modification, treating their hypertension, treating their obesity, treating their other comorbidities, so that we can hopefully help delay or don't see progression of that in their clinical course.
So in summary, in your large community cohort of subjects over the age of 50 without heart failure, valve disease, or reduced ejection fraction, this grade 1 diastolic function pattern, I guess we could call it dysfunction, was common, present in about a quarter of the patients. And it was associated with an increased risk for cardiovascular mortality and also an increased risk of death from dementia. Please note also the elegant editorial provided by Professor Thor Edvardsson, Assessment of Diastolic Function, Is It Time to Relax? Rethinking Echocardiographic Approaches. Enjoy the issue. Thanks for visiting with me, Katie.
Thank you so much. It was my pleasure.
Thanks for publishing in JASE.